I'm just going to hop over to Facebook very briefly and ensure that it is indeed broadcasting there. There we are. Okay. Got a few people joining already, so let's not keep them waiting. Let's start the show, folks. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this month and every month. And I'm a filmmaker and a writer, among a few other things, but I've been working with CCF for over 10 years now to create all kinds of video content, live video series like the one you'll watch today, patient-centric documentaries, dense treatment-based videos, conference videos, lots of different kinds of video content over that span of time, but all with the same mission in mind, and that is to help spread awareness and education about NETs. That is what we're here to do. Now, the show that we're going to have for you today, if you're not familiar, we're going to take some questions. Our special guest will respond to your questions, give you some good general advice. But the value, I think, is twofold on this show. I feel pretty confident to say the information you'll get from the guest is going to be very helpful for your journey, hopefully. But also the community within, the overall net community is very strong, but the community here within the show is powerful as well. So the sharing of stories and experiences and knowledge from people's personal journeys has been very impactful as well. So I say that to say, lean into that community. If you're new here, welcome. You might see people in the comment section saying hello, saying where they're signing on from around the world. We'd love to see how far these programs reach, but introduce yourself. Embrace the community. I promise you they will embrace you back. An announcement that I did announce last month, but I want to say it again, is that CCF is really excited to announce a partnership with LACNets to provide a support line for those affected by neuroendocrine tumors. So that support line provides guidance, resources, and referrals for NET patients or their loved ones. And this partnership formalizes LACNet's support line, which will now provide support to those contacting CCF in addition to direct inquiries. And so to receive support, we'll put this link in the comments section, but patients or caregivers can fill out a questionnaire available at lacnets.org. That's LACNETS.org/support line. Before we get started officially with the show, we want to thank our presenting sponsor, Ipsen Biopharmaceuticals, for their support of the series, because we couldn't do it without them. And we have this disclaimer we also like to include from them before we start the show, which is that the opinions expressed today by our guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested ahead of time by the sponsors of Lunch with the Experts, and CCF doesn't necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. So, audience members should not rely solely on the opinions or information expressed by our guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway. We're going to give you some good general advice, hopefully some good answers to your question, but take those answers and that advice back to your home team, which knows your specific case, and make the best plan and path forward for you. Okay, folks, today I am excited to welcome back to the show for, I am not exactly sure how many times you have been here, but Dr. James Howe is back to the show. I want to say it's 3 times now. Very good to see you. Welcome back to the show. How are you today?
I'm doing good, Rain. Thank you so much for having me again. Look forward
Absolutely.
to talking with the group.
Yeah, our attendees always really love what you bring to the table and the information that you share. For those that might not be familiar with you and the work that you do, could you tell us a little bit about where you work and the role that you fill in this neuroendocrine tumor community I alluded to?
Well, I'm a surgical oncologist. That means I do cancer operations on people, and I specialize in neuroendocrine tumors and endocrine tumors. I'm at the University of Iowa. We have a pretty long established group in neuroendocrine tumors, founded by Dr. Tom and Sue Odoricio back in 1999 with myself. And it's really a great community that we've been able to serve here, and I'm just so happy to be with a wider group here from across the country, and so happy to answer your questions. My background besides that is I've been involved in NANETS, which is the North American Neuroendocrine Tumor Society. I'm I was a president for a couple of years of that society, and also of the Society of Surgical Oncology, which is a national cancer surgery group. So anyway, so I've been doing neuroendocrine tumors since about 1999 as kind of a subspecialty.
So I know that in the past few years, there's been a lot of activity in the net world. Are there new tools that have come out recently that have helped you be able to perform your job better in terms of surgery in regards to nets?
You know, if we think about diagnostic tools, which I think is what the question's sort of referring to, I think the big thing that's been out for the last several years has been the gallium scan or the copper scan. The DOTA PET scans have been very useful for really defining the extent of disease in people. And I find it very useful as a surgeon to know, whether the tumors are localized to the small bowel and the mesenteric nodes, how many liver metastases there are, whether they're retroperitoneal nodes or skeletal metastases or even supraclavicular metastases. And so that, wasn't widely available in the United States about 10 years ago, and it's become really widely available where at most centers you can now get one of these scans that was really only available here and in a few other places in the country. So that has really, really helped us to do the preoperative workup.
Gotcha. So folks, before we start taking your questions, just a little bit of guidance in how you can frame your questions, which will help me do my job, which is, of course, to get those questions answered. Just remember that we, most likely our guest doesn't know your specific case, so try to answer in generic terms. It's really hard to answer in this format. Maybe, taking it offline is a different situation when we don't know your specific case. And it's very hard to include all the details of your specific case, which may be over the span of years, in just a paragraph. So try to ask questions if you can in short, generic chunks, knowing that you can continue to ask follow-up questions. There is no limit or no maximum of questions that you can ask, but that just helps us kind of get down the road and address that question a little easier. But our goal is to get that question answered. If you need further questions answered or have follow-up questions after the show ends, the show will live on Facebook and the other platforms it's broadcasting to, so you can always refer back to it. But if you have follow-up questions, you can reach out to ccf@carcinoid.org. And just a reminder, as I mentioned earlier, for those just joining us, that we have now partnered with LACNets to provide a support line. So if you go to their support line, you'll have access to that. And also if you message CCF, you'll have access to that. So we already got some questions rolling in, Dr. Howe. Let's not keep the people waiting. First question comes in from Nancy. It says, ST4 small bowel net. I had surgery 2 years ago at Penn, removing primary site, liver mets, gallbladder. It's been suggested that I start Wegovy. I'm not familiar with that term for weight loss. WYGOVY. Any contraindications that you're aware of with GI nets?
That's a really good question. Wegovy is like Ozempic. It's a GLP-1 antagonist, I think. I'm not an expert on these. It's a diabetes medicine, but a lot of Hollywood types have been using it to lose weight.
Got it.
But so I am not sure. I think that's a great question. I mean, it definitely has effects on GI motility. As far as contributing to the growth of carcinoids, I am not aware. That'd be a great question for Dr. Joe Dillon, my colleague in endocrinology, but I'm not sure if I can answer that for you. But I think it's a great question because that pathway is involved in in small bowel neuroendocrine tumors in some fashion. We studied it a while back doing RNA analysis and found that it was highly expressed. But how that translates into the drug treatment for diabetes that targets that pathway, I'm not sure.
Got it. Well, thanks, Nancy. We've had Dr. Dillon on the show a few times, so maybe you might be able to reach him, and we'll try to include his information if we can. And also a reminder that you can reach out to us after the show, and we'll try to get you to the right person to give you the right information. Next question from Timothy. Timothy says, as it pertains to liver debulking surgery, when shooting to get out 90+% of the tumor burden, and one surgery might be too dangerous, do you ever do the procedure staged in 2 operations? For example, surgery 1, pancreatic tail and clean out the left lobe, wait 6 weeks or so, and then surgery 2, get after the right lobe and the gallbladder.
I think that's a great question, and sometimes we'll do that with colorectal cancer. I wouldn't do that very often in neuroendocrine tumors. I would, the one exception would be when somebody has a pancreatic head mass and you're going to have to do a Whipple procedure, which is removing the head of the pancreas, and then you have to sew the intestine to the bile duct. And so if they have liver metastases and you're going to do surgery for it, you want to do the liver first, so that later on you do the Whipple, where now when you do the attachment to the bile duct and bacteria can get up into the liver, that those areas that you've treated are now healed. So that's something where we'll do a 2-stage procedure, but again, it's 1 stage in the liver, 1 stage in the pancreas. People with significant disease, I could see there being an argument for that, but going through 2 major operations 6 weeks apart is quite a bit. So my practice has been generally to, do the primary tumor and do the cytoreduction at the same time. If the disease is extensive, then, we'll resect the more easily resectable lesions and then do ablation of the deeper lesions, so we don't have to resect as much liver and we can preserve as much as we can. So that would be my approach, but I could see how there might be certain situations where you might want to do a stage procedure, but again, we haven't really done that very often.
Got it. Thanks, Timothy. Hopefully that helps. Next question from Rita, if I'm pronouncing that correctly. Rita says, I am being referred for possible PRRT treatment. I've had genetic testing and do have a variant that could make me more susceptible to leukemia. Is there a way to proceed and monitor someone going through PRRT more closely for this?
I think that's a great question. I am personally not aware of germline mutations, unless it's maybe a P53 mutation, but I'm not aware of the mutation that you're talking about that would make you more sensitive to leukemia. But it certainly is a concern about anybody getting PRRT. There's about a 2% risk of leukemia or myelodysplastic syndrome. There are ways to reduce dosage based upon your uptake of the isotope, and that's called dosimetry, where the PRRT center can evaluate and then modify the dose based upon the uptake of the isotope. So I think that's the only way I know of, is to make sure that dosimetry is done, and then if necessary to reduce the dose, because some people, there's a standard dose of PRRT, and some people it will lead to much higher levels, and other people lower levels. And if you're one of those people who have greater absorption, they could reduce the dose and still get the same effect. So that would be the only way that I know, is to do dosimetry.
Got it. Thank you. Another question from Timothy. Timothy says, could you please discuss the probability and warning signs of a pulmonary embolism following major abdominal surgery?
So warning signs, a lot of times what people might have, the most obvious sign is that people develop acute shortness of breath, and all of a sudden they're really having a hard time breathing. That's the most obvious indication of a possible pulmonary embolism. But sometimes there are more subtle signs like tachycardia. Most patients after major abdominal surgery are going to have a fast heart rate like that, but some people will have a resting heart rate that's faster than even you might expect for a post-surgical situation. And sometimes they'll have a low-grade fever, and in that situation we might have a low threshold to get the diagnostic test, which is basically a chest CT to look for a pulmonary embolism. But again, in its worst case scenario, you can have sudden really bad shortness of breath, or even heart failure, or sudden death would be the actually worst manifestation. But again, sometimes it's more subtle, and it's just a fast heart rate and some slight shortness of breath or oxygen saturation that's a little bit below the normal. And again, having a low threshold and getting a chest CT, you can figure it out really within 15 or 30 minutes.
Got it. Thank you. Next question comes in from Cindy. Cindy says, going for a consult for bland embolization on large liver tumor. I finished PRRT last fall, so I'm wondering if I should wait for alpha PRRT to be available before considering bland to avoid, rather, too much radiation.
Well, okay, it's a good question. So bland embolization doesn't have any radiation except for the procedure, the fluoroscopy that they use to guide the catheter. So that amount of radiation isn't really very much. So the other thing about waiting for alpha, so that this is a common question that people have, when is that going to be readily available? And there are trials going on now. And so we don't really know if that's going to be a year from now. I mean, you can get on a trial now, but for it to be standard therapy could be a few years. So if you just got PRT that finished last fall, you really want to ride the benefit of that as long as you can, which is on average about 2 to 3 years. And hopefully by that time, if there's further progression, the alpha agents will be available. So I would say, getting back to the question about embolization of a large liver lesion, I mean, it should be safe to do a bland embolization. I think the important thing, though, is not to get a radio embolization. That's where they put the beads are conjugated with yttrium-90 radioactive material, because there's some evidence, and this is still controversial, but there's some evidence that causes more radiation damage to the liver, and it could cause fibrosis and cirrhosis, that plus PRRT. So sometimes what will happen is the liver will gradually become more and more fibrotic and damaged by the combination of radioembolization and PRRT. So, and that might preclude you getting PRRT in the second round down the road. So again, bland embolization, I think in this situation is a better choice because that won't burn the bridge for future PRRT. But again, the radiation associated with the interventional radiology procedure is probably not that much. So I wouldn't worry too much about that part.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And today our guest is Dr. James Howe from the University of Iowa. And Bridget says, please tell Dr. Howe I said hello and thank him for all he does. Highly recommended, Doc. He saved my life. So thanks, Bridget.
Hi, Bridget.
Question from Joe. Can lung nets with liver mets metastasize to the thyroid?
I suppose they can. I've taken out neuroendocrine tumors of the small bowel metastatic to the thyroid. I'm not sure about lung, perhaps, but yeah, I mean, they can definitely go to the thyroid, although it's not common. So I think you could sort that out with a fine needle aspiration. If you had a thyroid nodule and you wanted to figure that out, a fine needle aspiration might show that it's a metastatic neuroendocrine tumor rather than a more typical follicular adenoma or carcinoma, which are a different looking kind of tumor that you might see in the thyroid.
Got it. And a kind of the other approach to the thyroid, Jeannie says, can the thyroid be a primary site for a NET?
Well, there is a certain neuroendocrine tumor that does originate from the thyroid, and that's called medullary thyroid cancer. And that is a neuroendocrine tumor of the thyroid. It's seen in a familial condition called multiple endocrine neoplasia type 2A and 2B. And there's another familial form without the other components of MEN2A, which are pheochromocytoma, which is a tumor of the adrenal gland that makes adrenaline, and hyperparathyroidism, which is a disorder of the parathyroid glands that sit behind the thyroid, where you get high levels of calcium, and that can cause issues like kidney stones and other things. But medullary thyroid cancer is a primary neuroendocrine tumor from the thyroid, and it's a little more aggressive than the more typical follicular and papillary thyroid cancers that are much more common in the population.
Got it. Thank you. And thanks for your question, Jeannie. Next question. Also, Jeannie, does the copper 64 tracer in scans light up only neuroendocrine tissue, or will it light up other types of tissues like other cancers?
So that particular copper isotope is conjugated to a somatostatin type analog. And those bind to somatostatin receptors. And those are receptors that are in high density in neuroendocrine tumors. There are other places in the body that will light up on a copper or a gallium dotatate scan, and that can include the pituitary, the adrenal glands, the spleen, the kidneys, the liver, and the bladder. So you'll frequently see uptake on those scans in those areas, even though there aren't tumors there. That's normal uptake. Also, the uncinate process of the pancreas is a common source of false positive uptake. Now, to fully answer your question, though, do other tumors light up with that isotope? Well, meningiomas sometimes in the brain will light up, but most other tumors, like a colon cancer or a ovarian cancer that's not metastatic from a small bowel tumor, will not. So it's fairly specific for neuroendocrine tumors. Also, pheochromocytomas and paragangliomas, which are a form of neuroendocrine tumors, will light up as well. So most tumors won't, because of its specificity to these receptors that are usually just present on neuroendocrine tumors and not most other tumors, although there are some exceptions.
Got it. Now, Robin says or asks, we were told that the copper scan was not beneficial or diagnostically helpful for poorly differentiated non-functional nets. So the question is, well, one, is that accurate? And if so, what other tools should we look for?
That's a great question. So, poorly differentiated neuroendocrine tumors don't have a lot of those receptors I was just talking about. And so what poor differentiation means is that the cancer cells are developing additional mutations where they're becoming uglier and uglier and don't resemble their more well-differentiated counterparts. And by well-differentiated, we also could say well-behaved if we want to use a human characteristic. So well-differentiated tumors have lots of those receptors, but as you become poorly differentiated, you lose your identity as a neuroendocrine tumor and you lose these receptors. So the gallium or copper scan may not show them up. Now, but still in many cases, they will have enough receptors to light up. Now, that's a case where an FDG or a glucose PET scan can be very useful, because as those tumors become more poorly differentiated, they'll take up sugar, which is the PET scan that we use for most other tumors. So that can be very helpful to do a FDG PET, which is a slightly different PET scan.
Got it. Thank you. From Tulin says, is there any correlation between or of nets and skin neoplasm?
Well, there is a primary neuroendocrine tumor of the skin, and that's called Merkel cell carcinoma. I'm not sure if that's what your question is, but we should just talk about that for a second. It's not. There are neuroendocrine cells in the skin that can develop into cancer, and these Merkel cell carcinomas are interesting in that they come from those cancer or those cell types, but they also have and there's a virus that is also behind their development. And so those tumors often can be metastatic to regional lymph nodes, and they usually present as kind of a purple colored mass under the skin. And those things are often very responsive to immunotherapy. So that's a few things to know about a Merkel cell carcinoma. Now, the other, I'm not sure if your question is asked about Merkel cell or the fact that other neuroendocrine tumors, say of the small bowel or the pancreas, can metastasize to the skin. And I think that's possible, but I've got to say that I haven't seen it that often. And we've certainly seen a number of patients with metastases to the breast, but that's not the skin, it's in the breast tissue. And that happens in a small subset of patients. We've seen that mostly in small bowel neuroendocrine tumors. So not a lot of mets to the skin, but the Merkel cell carcinoma is of the skin. I hope that answers your question, Tulin.
Me as well. And so if it didn't, or I didn't quite get that right, just let us know. You can always chime back in, and we'll try to get the right information to you. But thanks for your question. From Dorothy. Dorothy says several doctors on this show have said that they no longer use chromogranin A as a tumor marker. Do you use chromogranin A? And if not, what markers do you use?
Well, thanks for the question, Dorothy. We use chromogranin A, pancreastatin, and serotonin for small bowel tumors. And then in the past, we've used pancreatic polypeptide for pancreas as well as those other three. Whether those markers are useful is a matter of controversy. So the NCCN says the only thing to follow is a chromogranin A. Many people don't really find that valuable. We find that the pancreastatin is probably a little better than chromogranin A because it's less likely to be influenced by taking drugs like omeprazole, which can cause a chromogranin A to be high. Markers by themselves can be misleading. So it's really the combination of seeing gradual increase in the marker levels plus a CAT scan or an MRI showing progression that really leads us to change therapy. But a change in the markers alone may not do that. And those markers can go up and down. And that's why I think a lot of clinicians have abandoned following them, but we still find some utility in it.
Got it. Thank you. From Joe. Joe says, if thyroid has ill-defined hypoechoic taller than wide irregular nodule with microcalcifications, would the next step be immediate removal of half of the thyroid, biopsy, or something else?
Joe, that's a very sophisticated question.
Right.
What the couple things you mentioned are part of what's called the Thyroid score, which is an ultrasound-derived score of putting a risk category on a nodule that they see on ultrasound.
Okay.
And so when the thyroid score is like 4, 5, or 6, and the nodule size is over, say, 1 to 1.5 centimeters, then biopsy will often be recommended. And then it's really the results of the biopsy that will determine whether you do a thyroid lobectomy, which is taking out that 1/2, versus a total thyroidectomy. So your question was very specific, but I think it was missing the biopsy part. So you want to, if the radiologists say it's in one of those higher risk categories and recommend biopsy, which is really nice because this classification wasn't really around or wasn't used a lot until the last few years. And it's really helped us as surgeons to know which lesions need to be biopsied and which ones are at highest risk. So again, if it gets that higher thyroid score and biopsy is recommended, do a fine needle aspiration. And then we did make the decision on surgery and how much. So
Okay.
yeah, maybe.
Yeah, I think that answers. Let me know, Joe, if you have a follow-up question. But that was one of the options. Was it a removal of half the thyroid, biopsy, something else? So sounds like we got to that. Appreciate you all being patient with me, churning through that. Would you call it a specific question? Or sophisticated question? That's what you call it.
Yeah, very sophisticated.
Yeah. Terry says, my husband went through 2 rounds of Captem, which caused him severe issues and ended with him spending a week in ICU with severe anemia. Sorry to hear that, Terry. Nausea and other things. He had a Whipple in 2016. He's still getting lanreotide injections monthly. Since he had such a horrible time with the side effects from Captem, would you recommend what would you recommend next? And when he's still not feeling better, from all that happened on Captem.
Okay, well, so a Whipple in 2016,
Correct.
And then Captem recently, probably because there was progression, maybe some liver lesions. I'm presuming because you wouldn't use Captem unless that was the situation. Captem is an excellent combination. It probably has the highest response rates of any treatment that we have for well-differentiated PNETs. Okay. But in pancreas, there are several other options. So as far as drug options, there's sunitinib and there's everolimus, and those are more targeted drugs to certain pathways, but they have side effects, and the response rates in terms of tumor shrinkage are generally minimal, but they can delay progression. So there are options. But I think the other really good option with PNETs that I would go to next might be with PRRT. And I don't think you mentioned that he had PRRT, but that certainly can be a good option. That in the NETTER-1 trial that focused on small bowel tumors, but now if the FDA has approved it for pancreas as well, it showed good progression-free survival, in the 2 to 3 year range. So that is a good option if CAPTEM is not well tolerated.
Got it. Thanks. Appreciate your question, Terry. Hopefully that helped. From Kathy. Kathy says, I had small cell carcinoma in my cervix. I had a radical hysterectomy followed by chemo. I had a recurrence and radiation. My PET scan shows growth in my liver of a lesion that they have been watching. I need a liver biopsy. The question is, could my treatments have caused my lesion to grow?
The liver lesion grew with chemotherapy for the small cell, is I think what you're saying.
Yes.
If the liver lesion's also, of the same type, which is what we would think would be the most likely thing, then, it would normally cause it to grow, but it's possible that if something metastasized the liver, maybe it's developed some more aggressive characteristics that it's no longer sensitive to that chemotherapy regimen. Small cell cancers are, poorly differentiated cancers, and they are generally treated aggressively with chemotherapy like cisplatin and etoposide. And if those agents are not working, and this is a small cell in the liver, then other regimens need to be considered. And again, seeing a medical oncologist who treats these types of tumors would be really important for that.
Got it. Hey, thanks, Kathy. I appreciate your question. Next question from Nancy. My last PET scan showed that possibly, GI net may have spread to the iliac bone. What is the usual treatment for that if it's confirmed?
Okay, so Nancy, I'm assuming that you've had a resection of a GI net, and this is a follow-up PET scan that showed for the first time a bone lesion. Unfortunately, that's a common finding, and I'm sure lots of people who are watching this have had PET scans that show bone lesions. Bone lesions are, they're often not problematic unless they're causing weakening of the bone in an area. So in most cases, they have to be of a certain size and can lead to fracture. But I would say most of the lesions we see in patients are relatively small and really don't require treatment other than somatostatin analogs that the patient might already be getting. But in those larger lesions where there might be some threatening of the integrity of the bone, then radiation to that spot can be helpful. So most lesions don't need to be treated. The ilium that you mentioned is a pretty strong bone in the pelvis, and it's unlikely that would need to be treated with radiation. But I saw a gentleman yesterday who had a metastasis to the humerus that looked like it occupied, which is the upper arm, which occupied about half of the bone. And that person, I worry a little bit more about, that he could develop a fracture at that area because the tumor weakens the bone. But again, most of the bone metastases, you're not going to treat with radiation unless there's that kind of threat of fracture. And then, somatostatin analogs, PRT, and systemic therapies that get to your whole body can help to keep those areas from growing.
Got it. Thank you. Question from Mary Helen. Mary Helen says, can you tell us anything about the clinical trials for a lanreotide pill? I'm not familiar with that.
Yeah, so that would be another great question for Joe Dillon, because there is a somatostatin analog. I don't think it's lanreotide per se, but It's a somatostatin analog that can be taken orally. And believe trials are either about to start or have started with that agent. And, that would be very useful if people could avoid getting that monthly shot in the buttocks that can sometimes inflict pain, and the slow release of this 5 mils of sandostatin or lanreotide. It's kind of a deep sub-Q, but still it's a big needle, and people, can be uncomfortable from it. So I think those trials are just beginning. So it's going to be a few years, I think, before we know how good they are.
Gotcha. Question from Lynn. Lynn says, I had gene testing done. Report says MEN1. However, the doctor says I don't have MEN1. So I'm very confused. I get that, Lynn. Any thoughts or what she should do at this point?
Okay, so gene testing showed a mutation in the MEN1 gene, but your physician says that you don't have MEN1. So it sort of depends on what the gene testing said, and it would be good to hear from a genetic counselor what their thoughts were, because sometimes you'll find changes in a gene like MEN1 that aren't changes that have been seen before, or maybe don't change the protein that's made by that gene enough to think that it would cause the MEN1 syndrome. And those things are called variants of indeterminate significance, or VUS. And so a lot of those things, it's sort of hard to know, is that really a mutation that we need to worry about or not? And then there are the things that we're pretty sure about, and those are called pathogenic mutations. So anytime you get a genetic test results, you're going to see these VUSs, variants of undetermined significance, and maybe a pathogenic mutation. So it sounds like maybe you had a VUS in the MEN1 gene. And then it's also important to know that some patients with MEN1 are going to have a negative gene test, but about 10% of them still have the syndrome because perhaps the mutation is in an area of the gene or an area near the gene, like in the promoter region, that has not been identified. So anyway, and why your physician said you didn't have MEN1 could be that maybe you don't have all 3 components, although you don't need all 3 components to have MEN1. That's basically multiple endocrine neoplasia type 1. And the most common feature of that is hyperparathyroidism. And then some people get pituitary tumors in the brain. And then some people get pancreatic neuroendocrine tumors. And then some people can get thymomas, benign adrenal tumors, and some people have even suggested small bowel tumors, but that's not as frequent. So it's a long-winded answer to your question, but there are some subtleties to genetic testing, and not all physicians can interpret those test results as well as a genetic counselor. So usually if you had testing done, it was in the setting of seeing a genetic counselor, and you might want to ask them, which category that mutation was.
Got it. Thank you. Let's see. We got a few more here. Lydiana says, can regular PET scans see nets?
And when you say regular, I think you're talking about an FDG PET, which is, we talked a little bit about that with the poorly differentiated tumors. So an FDG PET will not light up as much on a well-differentiated neuroendocrine tumor, but sometimes they'll light up. I mean, I've seen some patients in the last several months who had an FDG PET where the liver metastases showed up a little bit. But the gallium or copper dotatate PET will show them much better. So in general, it's not a good screening test for metastatic neuroendocrine tumors. You can't reliably expect them to light up with an FDG PET, but sometimes they do.
Got it. From Kimmy, and hey Kimmy, I feel like this might be the first time I've seen your name. So if you're new to the show, welcome. Kimmy says, what SUV number is considered to have receptors on tumors?
Well, in an FDG PET, they use a cutoff of about 3.
Okay.
And less than 3 is equivocal. For a DOTA PET, I think 3 is kind of equivocal, and over 5, if you see 20, see 50, I mean that's kind of a lock if you're up in that 10 to 20 range. 5 is pretty high as well. So it's a little fuzzy when you get down below 3, I would say.
Got it. Deborah says, is there any way to tell if an adrenal nodule is cancerous just by a CT scan? If the nodule has grown, what is the protocol? Should it be removed, and could it be the cause of an increase in heart rate by chance?
Okay, excellent question about adrenal nodules. So a lot of people have adrenal nodules that are seen when they get a CAT scan for some other reason. I think I saw 2 people in clinic yesterday who were seeing me for that very reason.
Wow.
And the reason to take out an adrenal nodule is if it's making a hormone, adrenaline, aldosterone, or cortisol, because they can make any one of those 3 hormones. And all those 3 hormones can cause problems. And when you talk about a fast heart rate, if it's making adrenaline, that will absolutely make your heart rate faster, cause sweating, bad headaches, palpitations, and other things like that. So anytime we see somebody with an adrenal mass, we'll check levels either in the blood or the urine of those hormones. Now, some people don't make those hormones, and then it comes down to, okay, how big is that lesion? If that spot in your adrenal is over 4 centimeters, that's a cutoff where we'll often recommend that it be removed, because as it gets larger and larger, the risk of it becoming cancerous, despite the fact it's not making a hormone. But when it gets over that size threshold, some people use 4, other people use 5, but as it gets larger, the risk of cancer will get higher. Now, in terms of knowing whether a lesion in the adrenal is actually a malignant tumor, for those smaller nodules, they're very commonly benign. But when they get real large, if it's 10 centimeters, there's a good chance that that might be malignant. If it's 6 centimeters, or one of these smaller tumors, then it may still be malignant. They may have a different shape. It may not be as round. It may be more irregular. There are metastases from other tumor sites that can go to the adrenal gland, lung cancer. I recently took care of a metastatic endometrial cancer. And those tend to be irregular looking, and the adrenal gland is not a round or oval mass. So biopsy in that situation can be helpful to look for a metastatic tumor, but in general, adrenal biopsy is not that helpful, and so we wouldn't routinely do that.
Got it. Thank you. Folks, we've got about 15 minutes left. We're going to keep moving forward. Great questions today, by the way. Next question comes from Jeannie. It's a little dense, but let's get through it. Jeannie says battling Cushing's, pituitary surgery last year with remission for 3 months, now in recurrence. Extensive testing shows that the source is no longer pituitary. I have high 24-hour urinary 5-HIAA, thyroid lit up with copper 64 scan. So the question is, could thyroid tumor / net possibly be an ACTH producing net?
Well, I've got to say that I haven't seen a thyroid tumor make ACTH.
Okay.
I've certainly seen it in pancreas, ACTH producing tumors. I suppose any neuroendocrine tumor, if it's dedifferentiated enough or devolved into some other entity, could make ACTH. But I can't say I've ever heard of a thyroid cancer doing it.
Okay.
Checking if the ACTH levels are very high, which I presume they are, then I guess it would be important to kind of look at the whole body, which you probably have done. You mentioned having a PET scan, the thyroid lit up. I guess if that were a neuroendocrine tumor in the thyroid, a fine needle aspiration could tell you that. But I would look carefully at the area of the pancreas, because those are more likely to make ACTH if it's not a recurrence of the pituitary tumor, which is probably the most common thing that might be doing that. So if you've had an MRI, it doesn't show any recurrence in the area of the pituitary. and you're looking throughout the body, could it be thyroid? Maybe, but that'd be a little bit of a long shot. But again, if I needle aspiration that showed that was a neuroendocrine tumor, and then nothing else was seen elsewhere in the body. And again, this might be a case where not just getting a gallium or a copper PET, but also getting an FDG PET, because tumors like that might be less differentiated. So those are some things to think about in the workup.
Got it. Thank you. From Timothy, do you ever do liver debulking surgery on the same patient twice with a long period of time, let's say 3 years, between the surgeries? We talked earlier about a shorter period. Can you do liver debulking surgery 3 times over a 10-year period?
Yeah, you certainly can. It gets harder because after you do that surgery, the liver sticks to the diaphragm, and it can take a lot of time just to get the liver off the diaphragm without causing it to ooze a lot.
Mm-hmm.
So it gets harder, but there are certainly a number of patients that I've operated on where I've done cytoreductive surgery, like liver debulking up front with the removal of the primary. And then over time, years later, often not within 3 years, it's often even later than that, because we'll usually try somatostatin analogs. We might give PRRT, or even embolization. But then if the lesions continue to grow after these other treatments, I'll take patients back. And if I think their liver lesions are amenable, if I think I can get them, and the number we use is 70% or more.
Mm-hmm.
The earlier, one of the questioners, brought up the 90% threshold. That's a matter of debate amongst people who do these operations, whether you need to get 70 or 90%. But if people, have 5 or 6 liver lesions that over the last few years are getting bigger and bigger, and I think I can do cytoreduction, then I will.
Got it. Thank you. From Paola, how common is it to have a secondary primary or second primary?
Okay, so a couple different ways to answer that question. So, in the small intestine, it's very common for people to have multiple primary tumors.
Okay.
And so we did a study, and we found that 54% of patients had more than one tumor in their small intestine. So that's a second primary. But if you're talking about having, say, a primary in the small bowel and then developing one in the pancreas, well, we've also seen that in a lot of patients. And what it turns out to be is that a lot of those patients with a neuroendocrine tumor in their pancreas who've had one in the small bowel are actually metastases from the small bowel to the pancreas. We published a paper with 11 patients who had that situation, and in 2/3 we were able to show by qPCR, which is a molecular technique, and immunohistochemistry, that the things that ended up in their pancreas came from their small intestine. And that can be very helpful information, because pancreas surgery, especially if the lesions in the head of the pancreas, will require a big operation. And if it's a metastatic tumor, and there are also tumor metastases elsewhere, like the bone or the liver, you have to think long and hard about whether you want to do a pancreatic surgery, because it has more complications than other surgeries. And if it's one of many metastases, you might want to think twice about it. In terms of having a second primary elsewhere, like in the bronchus, in addition to the small bowel, I guess that can happen, but that's not too frequent.
Got it. Thank you. And thanks for your question. Next question from Leslie, joining us from YouTube, says, how effective is oral chemo for tumors in the liver if PRRT is not an option?
So oral chemotherapy for pancreatic neuroendocrine tumors can be very good. That's capecitabine and temozolomide. Those are given orally, and the response rates are as high as 40%, getting decent shrinkage of those tumors. And, in our experience, it seems to me that maybe the response rates are even higher than that. But that Dr. Kuntz, who published a paper this past year on their experience as a large randomized trial looking at temozolomide versus capecitabine and temozolomide, showed those kind of responses. So that's a pretty good chemotherapy for PNETs. But for small bowel neuroendocrine tumors, which are a little more common, then there isn't a good oral chemotherapy. There's everolimus, which is an oral targeted therapy, and that can slow down progression-free survival. But often you don't see a lot of shrinkage.
Got it. From Shane, what might be considered an acceptable PFS after liver embolizations to consider retreating the patient with embolizations again, retreating the patients with embolizations again after progression?
And I assume you're talking about the same lesion, because a lot of times you'll do one side of the liver and then the other side in some staged fashion. But I don't know. I think you'd like to get a couple years, 2 years or so. There's no hard and fast rule about that, but trying to get a couple years from that first embolization would be, a reasonable amount of time if you saw growth to perhaps do it again. So yeah.
Got it. From Lisa says, my oncologist doesn't seem to think serotonin levels matter. He wasn't testing it at all until I requested. We've now been watching my numbers climb every month, and oncologist says there's no treatment for high serotonin levels. Is this true? I've been on Sandostatin for almost 5 years and getting more symptomatic every month.
So again, serotonin as a marker is controversial. Most people don't check it. We check it routinely, but it can be misleading. Serotonin can be affected by whether how the blood is drawn, because it can be released from platelets. It's in certain foods like avocados and nuts. So it can be affected by a variety of things, and it's not completely reliable, but patient symptoms can often correlate with the levels of serotonin. And we find it's pretty valuable to follow over time. So the treatment of serotonin, yes, you can treat with somatostatin analogs, which can help reduce the symptoms of high serotonin. And then if the symptom is diarrhea, then telotristat can be helpful for that, because it inhibits the enzyme tryptophan hydroxylase, which helps to make serotonin. So there is a drug that treats serotonin production. The effects of that drug are somewhat modest. I mean, people have reported a reduction in the number of daily bowel movements, but not a huge reduction. But that is an agent that is more targeted at serotonin.
Got it. Thank you. Here's a good question from Gwendolyn. Gwendolyn says, while the 70 to 90% numbers necessary for debulking make sense, how would even a 30 to 50% not help a patient feel better? Is it primarily a risk issue or factor?
Yeah, liver surgery is risky. There's risks of bleeding, infection. It's a big operation to get exposure of the liver. It's hard to do that without a large incision, so you pay a price for that kind of surgery.
Mm-hmm.
And the problem with neuroendocrine tumors in the liver is that they tend to be multifocal and they can be all over the liver. And so just getting a small fraction out may reduce levels of serotonin and other hormones, but probably not for very long. And it's probably not worth it to go through all that, the risk and the recovery of surgery for, just a minimal reduction in those numbers, because it's going to be, the effects will be short-lived. So that's why the 70 to 90% numbers come in, is that you hopefully get rid of the bulk of the disease so the other stuff can grow slowly. But if you leave a lot in there, then that'll still be producing the hormone, so you won't get much benefit.
Got it. Interesting question from Shane, which might be a general cancer question or kind of outside of the oncology aspect. But the question is, what are your thoughts on stress and its impact on net growth? My mom was stable for 2 years and experienced her first growth after the passing of her father in retirement. Coincidence, perhaps, but would love to hear what you think or what you might have seen throughout your career.
Well, I think it's a great question, and we all think that stress contributes to disease, and some people think bad outcomes, but I've never really seen that well quantified. So it's really hard to know, in what way does that happen. So I don't feel like I have any data to offer you to tell you that how stress impacts the outcomes of patients. And have I seen people negatively affected by stress and have negative outcomes? Well, everybody I see is under stress because they have these stage 4 cancers. We're doing big operations, and those patients can still do real well. But I do think that it probably has some effect, but I'm not really sure how to quantify that.
I guess we can maybe say it doesn't help, maybe, but
it's hard to not be under stress if you have a tumor.
Right, right, and it's really hard to put, like you said, put data to that. It's kind of a generally accepted thing, but yeah, it's really hard to align that with some data. But thanks for your question. I think it's good for us to take, to have these kind of conversations and help people forward. And this is also back to my initial point at the very beginning of the show. This is also a good question or topic that I see the community speaking with each other about their shared experiences really is valuable. Like, I feel that way too, and I do this. So I've seen that a lot too. So if anyone wants to chime in, of course, feel free to. Just a couple more minutes, so maybe time for 1 to 2 more questions. Bob says, do well-differentiated P-nets eventually become poorly differentiated? Had a P-net removed and liver mets debulked last October.
Well, it's something that we're paying a lot of attention to now. And there's a group of patients who have had their tumors removed and maybe even liver cytoreduction who might have a liver lesion, grow slowly over time. Then all of a sudden it grows really quickly. And in that situation, that's suspicious for the situation you bring up, something converting to a poorly differentiated tumor. And so in that situation, we'll do a biopsy to see what the Ki-67 is. And a lot of times we'll see that it's very high, and that'll tell us it's transforming to a higher grade tumor. And then how you treat that really depends on whether it's poorly differentiated, because those patients will get some form of chemotherapy, or if it's still well differentiated, but in the grade 3 category. And that means that Ki-67 number is over 20%. Some of those patients I've gone back to resect when it's a single lesion. It's still controversial whether that's helpful or not, because the higher that Ki-67 number is and the more poorly differentiated it is, there's a higher chance that other spots are going to start to show up. And so just treating one growing lesion may not take care of everything. So we're seeing this more and more, but I can't say it's a frequent event. So I don't want everybody out there to be panicking that, this is going to happen. But we've seen it maybe 5 or even as high as 10% of people who have been followed long term. So if you have rapid growth of a single lesion or rapid expansion of the amount of tumor, say, in your liver, then that's where you really want to be thinking about that kind of transformation.
Got it. And folks, as I mentioned just a little while ago about sharing your own experiences, Tracy says stress is one of the worst things for my carcinoid syndrome, for example. As soon as I start feeling stressed, I get an attack. So that's kind of what I was talking about. Thanks, Tracy. I appreciate you contributing that. Folks, that is our show for today. That is our hour. Thank you so much for everyone attending. As always, we hope this program helped answer some of your questions. Sarah says, thank you for the presentation. Always very informative and educational. Dr. Howe, thank you as well for being here. I appreciate your time.
Thank you, Rain, and thanks to everybody who tuned in, and thanks for your questions. Hang in there.
Absolutely. And folks, just a reminder, I see a couple of questions came in right there at the last minute. Just want to re-announce that our partnership with LACNets allows us to field those questions if you follow up with us at carcinoid.org or at lacnets.org. I think, yes, lacnets.org/support line. So we can give you any answers and information and referrals that you might need to get you further down the journey. We appreciate your time as always. And thanks again to our presenting sponsor, Ipsen Biopharmaceuticals, without whom this program couldn't be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.